Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare, and we're a proud community partner with Forward Radio here on WFMP LP 106.5 forwardradio.org. Here in the studio today with Doctors Michael Flynn and Dr. Gene Shively. Guys, what have we got going on today?
Well, Mark, let me begin with the usual disclaimer that any comments, positions that I make today represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville.
I would like to say that what I say represents my own personal views and not Taylor Regional Hospital nor the Department of Surgery at the University of Louisville or the University of Louisville.
So our topic today is going to be administrators, managers, bean counters. Who are they? Why are they there? Why are there so many? And depending upon the time, we may or may not get into electronic health records. So what I would propose that we do initially is let me provide a background of healthcare in this country today. And then I'm going to ask Gene to provide some comments on the financial situation. He's got a lot of really good data about that. So the major issue in this country, at least in my opinion, is that we consider health care a commodity, like groceries or automobiles or gasoline, as opposed to an essential public service. Most of the other, in fact, all of the other first world countries, the 30 plus of them, consider health care a public service and an essential and a government responsibility. And I've done this in an assortment of different ways. These are all market economies. They haven't gone bankrupt. And their basic function is to provide all of their citizens some reasonable amount of health care. Now, in some of these countries, private health care is available if you want to pay for it, and it may provide you some opportunities to kind of get to the front of the line. And in other countries, this is not allowed. So there's a lot of variability. What they don't have in those countries, which exists in our country, is 70 to 80. In our country, we have 70 to 80 million people who are either uninsured or underinsured and vulnerable to bankruptcy because they can't pay their medical bills. Now, I've wrote an article for Louisville Medicine last year about this, and went through the process of collecting information on the internet, and I really couldn't find very much information about medical bankruptcy in other countries. I found one article that indicated there was one example of a medical bankruptcy in France, country of 70 million people, in 2017. We had a Canadian surgeon on earlier last year, Ted Young from Ontario, Canada, and we asked him about medical bankruptcies in Canada, and it's just not something that happens. On the other hand, in this country, we have 200,000 to 800,000 medically related bankruptcies every year, and that medical bankruptcy represents the most frequent reason why people apply for bankruptcy in this country. So just a little bit more about the the existence of health care in this country is not really a system. I've heard it called a patchwork, or I think a crazy quilt is probably probably a better description. So we have Medicare, which is a government-funded health insurance program that covers not all but most of the costs of medical care, hospital and physician care for members of the population who are over 65, and some special circumstances, people with disabilities who are under 65. We have Medicaid, which is a government-funded, both federal and state, for those under 65 with some financial limitations. Now, Medicaid is different things in different places. In Kentucky, Medicaid is a pretty good coverage for the poor. It was expanded by a previous governor. It's not the same in other places. Other states like Tennessee, Texas, and maybe Arkansas or Arizona, I'm not sure of all the list of them, have not expanded Medicaid, and Medicaid doesn't provide very good coverage for those individuals in those states who are have some financial issues. And we have the VA system, which is a government-run, not-for-profit system that covers veterans. And this is actually, I think, is a pretty good program. There are outpatient facilities. There are VA hospitals all over the country. It's not perfect, but it's a pretty good system, and most of the veterans are actually pretty happy with the coverage that they get. The branches of the armed services, the Army, Navy, and the Air Force, all have health care systems which are managed by the Department of Defense. These are not-for-profit systems. They provide health care for the active duty members, retired, and for others as well. You remember that President Trump, when he contracted COVID-19, got on a helicopter and went to a flagship military hospital in Washington, D.C. to get treated. John McCain has had some melanomas removed at the Naval Medical Center in Bethesda. Ronald Reagan had his colon cancer resected. And Mitch McConnell had some surgery done as well. So a lot of politicians get free medical care in the military hospitals. And then we have over 1,000 for-profit health insurance companies that have put together an insanely complex healthcare system, which is really one of the major difficulties with healthcare in this country. So, Gene, having laid those, laid out the table like that, maybe you could make some comments about the really good research you did on the financial situation with healthcare in this country.
Well, one of the biggest problems with our healthcare system is so expensive. It represents about 18% of our GNP, and that's the highest in the world. Canadian system is about 12%, and other first-class countries who are wealthy are much lower than ours. And looking into the cost, it's phenomenal how much money we waste. For example, we're the only country in the world that advertises. They are the only country where physicians, pharmaceuticals, hospitals advertise. Only New Zealand allows pharmaceuticals to advertise. That's a total waste of money. other people do much better is in healthcare outcomes than we do. Another big part of the waste of money is the administrative burden. And I was really kind of surprised at how much that cost us. For example, we spend approximately 34% of our healthcare dollar in administration of healthcare, where Canada spends about 12%. So what does that mean? Well, it means that if you walk into a doctor's office or to a hospital and there are these huge numbers of for-profit insurance companies, and they all got different forms, they've all got different pre-authorization, they've all got different ways that they pay hospitals and doctors. This creates a phenomenal bureaucracy that other countries don't have to deal with. For example, in Canada, there's just one place that you bill, you get paid, but in the United States, we have to pre-authorize things. We have to go back and forth with the insurance companies. The hospitals have to do the same thing. Since the 1970s, there's been over 300% increase in the number of administrators in our healthcare system, which is just mind-boggling. For 16 people who work in our healthcare system who are in administration, only 6 of those patients or those people have direct access to patient care. The rest of the people are working in offices on computers, trying to figure out how they're going to get paid, what the patient has to do. And for the patient, it's almost impossible to figure out what they have to do because nobody really understands it, and each insurance company is different. Let me just give you an example of the overhead. In the Healthcare Advantage plans that are being pushed really hard these days, which represents about 40% of our Medicare patients, the overhead is around 14%. For the private Medicare patients who go through for-profit insurance companies, it's about 12%. For Medicare alone, it's less than 2%. So Medicare is holding down administrative charges while the private insurance are spending lots of money on administrative charges. Let me just give you an example. In the United States, we spend $2,497 per capita on administrative charges for a patient. In Canada, it's $550. In the Netherlands, they spend approximately 20%. In England, they spend 16% in administrative charges. Approximately half of a provider's overhead is in administrative charges. We have offices who have this phenomenal number of people who are sitting back in an office trying to figure out what they're going to do with these insurance. No other country in the world has that. That's one of the reasons that so many doctors are not working for themselves anymore. They're working for hospitals or for very large groups because they cannot keep up with the number or the administrative problems in healthcare.
Gene, I remember earlier on one of these programs you told us how much money is in the healthcare system and how much is not used for healthcare.
There's approximately $3.6 trillion I don't even know how to write that out. I'd have to look it up.
A lot of zeros.
And then about a third of that, which is $3.2 trillion, is wasted. Has nothing to do with direct health care.
Yeah, now that's a really, really important point, that 1/3 of the resources, the finances, the revenue that goes through healthcare in this country is not used to pay for healthcare.
That's right.
And that's the issue that we're talking about today when we get to these bean counters and bureaucrats. In the country of Taiwan, a little small country that has a universal health care program, they spend less than 2% on non-health care costs. Over 98% of the revenue in the Taiwanese healthcare system is used to provide health care.
And that's very important. And now, people are talking about Medicare for all. We all want a single-payer system. It looks like politically it may be impossible to get that, but we can take certain things and cut the cost. For example, administrative charges, defensive medicine, pharmaceutical charges. We may be able to get our healthcare costs down to a reasonable level by just picking out certain items which can dramatically reduce the cost of medicine in this country.
All right, let's kind of not go back to the beginning, but go. The topic is administrators, bean counters. Who are they? Why are they there? And why are there so many? You gave some numbers a little while earlier, Jane. I've got similar numbers, but they're a little bit different. This is based upon a New York Times article from June 9th of 2019 in the business section. And this basically indicated that from the mid-1970s to the mid-2010s, or the late 2010s, the number of healthcare administrators, I think you said they increased 300% in this time frame. Based upon that article, there was over a 3,000% increase in administrators, in managers in our healthcare system in this country. There are 10 of them based on every one of us. And then there's another similar article from the Bureau of Labor Statistics that basically shows the same thing. And then there's a third article in the Harvard Business Review. And again, the numbers may be a little bit different, whether it's 300%, 3,000%, whatever. Over this period of time, there's been a huge increase in the number of these people who are not providing health care, but they're in the process of managing the system and managing the money. And as you mentioned earlier, the health care has gradually changed from a system that takes care of patients to a system where there's paperwork and computer work based on billing. So if you look at some of the other components of healthcare in this country that I mentioned earlier, I was in the Navy for 20 years, 2 years on active duty and 18 years in the reserves, and worked in naval hospitals in this country. There's a naval hospital in Naples, Italy. I did a number of other things. If you're in the medical corps in the Navy, and I'm fairly sure it's the same in the Army and the Air Force, you're a medical corps officer. If you are an administrator in the Navy, and again, I'm pretty sure it's the same in the Air Force and the Army. I don't know that for sure. You are a medical service corps officer. There are more medical corps officers in the Navy than there are medical service corps officers. So in our healthcare system in this country, there are 10 of them to every one of us, whereas in these 3 examples of nonprofit systems, there are more healthcare providers than there are administrators or bean counters.
Well, another problem with that is those administrators are making decisions which affect medical care, and they are really controlling the insurance industry, the hospitals, and directly and particularly indirectly, they're affecting medical care. And sometimes they don't realize it, and a lot of times they have the power but not the ability to think about patient care. It's one thing to make a decision at your desk at 10 o'clock in the morning, and another thing to be up all night taking care of a patient, and there's a tremendous difference between that.
Well, there are even simpler examples than that. As more and more physicians are employed by these healthcare organizations, they get into the situation where the bean counter is sitting behind the computer looking at the flow of patients, and they're encouraging the physician to see X a number of patients or to spend X amount of time, with any individual patient. And as we both know, when you walk into a room, whether it's a surgical follow-up patient or whether it's somebody you've not seen before, you could be in and out of there in 10, 15 minutes, or you could be in there for 45 minutes. And I know in Louisville, in one of the healthcare organizations, people have left because they were encouraged to see, and these are medical people, they're not surgeons, but encouraged to see X number of patients in X period of time, or to see one patient every 15 minutes, or whatever that time frame was. The administrators are providing guidelines about healthcare, how that should be delivered.
Well, another problem that's kind of the opposite of that, if a patient calls in at 3 o'clock in the afternoon, maybe it's somebody that you know real well, has a complicated problem, the offices are encouraged to send those patients to the ER. It may be a patient that I know real well, and I can solve the problem in 5 or 10 minutes because I know what's going on. If they go to the ER doctor doesn't know that patient, and he ends up doing all types of lab and CAT scans, and finally, after several hours, comes to a conclusion that you could have made in just a few minutes.
Yeah.
And this really creates a problem.
Yes. Let me give you another example of that. I retired about 2 years ago, and the last 10 years of my practice, I was basically an endocrine surgeon as opposed to a surgical oncologist or a head and neck surgeon. And this is a very narrow area of specialty, and you get a lot of referrals from a lot of different sources. And one of the things that I noticed in this, as these organizations, these healthcare organizations came together, they are often, the basis of them is the hospital systems, Norton's, Baptist, Clark County, whoever they were. That they and I learned this from some of my referral sources, that within the organizations, they were encouraged to refer within the organization, not to refer outside of the organization. And what I noticed over the last part of my clinical practice was I would see I have a referral physician that was pretty reliable, and I would see X number of patients in a period of time, an endocrinologist, and then there was this period of time when I didn't. They seemed to have gone away, and I knew the disease didn't go away. It was hyperparathyroidism, and then I was seeing patients who had been operated on by somebody who really didn't have any business doing this in the first place, and there were failures. And there's again, this is just another example of the administrative influence on what would be a normal practice of referral to a treatment source.
Let me just remind our listeners, you're listening to Single Payer Radio with Doctors Mike Flynn and Gene Shively.
Let me approach this in a little different way to give you a little different perspective. In the healthcare industry, there are 770 workers per $1 billion of revenue. If you look at that in the normal industry in America, there are about 100 workers per $1 billion of revenue. If we practice in the United States like they do in Canada, we could save $600 billion. So that's close to half the amount of money that we waste in our healthcare system in this country. We could eliminate all the problems with the no insured patients, and we could probably eliminate all the co-pays and deductibles if we just use a similar system in reducing the administrative charges in our healthcare system.
Now, what we've been talking about, in my opinion, in a broad overview sense, is the corporatization of American medicine, and so we're not dealing with. When I came to Louisville, there were all kinds of practices, surgical practices, medical practices that had 2 or 3 people, or 15 or 20 people, and they went from one hospital to another. You drove around Louisville in your car, and that's the way it was back in the 70s and 80s, and then in the kind of the 90s, things started to change, and the hospital systems coalesced. I'd like to. There's a couple of examples of the influence of the bureaucrats, the bean counters, and the administrators that I thought we might focus on a little bit in a more specific way. And there were 3. One are the pharmacy benefit managers. The others are the for-profit health insurance company. And the third one is investor-owned health facilities. Because when you talk about changing the system to make it more efficient and save a lot of resources to be used for health care, these people are invested in not in doing just the opposite. Their goal here, these are for-profit entities that are taking money out of health care for mostly for profit or for some other reason. When you mention that 1/3 of the $3 trillion is not used for health care, it's going into the pockets of the pharmacy benefit managers, the for-profit health insurance companies, and the people who invest or own nursing homes. So let me let you respond to that, and then maybe we could focus a little bit on pharmacy benefit managers for a bit, because That's something that made my hair stand up on end when I started looking into this.
Pharmacy benefit managers. I don't know exactly what they do. And I've talked to a bunch of pharmacists, and a lot of the pharmacists don't know what they do. But I can tell you they're making a lot of money.
Yeah, no, and that's the key. Transparency. They don't want you to know what they do. They are the middleman. This is a for-profit company that takes a cut of just about everything it does. Now, the way I understand this, this is the middleman between the drug company that makes the drugs, the wholesaler who sells the drugs, the pharmacy who dispenses the drugs, and the insurance company who pays for the drugs. And so they've got their hands in the cookie jar of all of these organizations, and they're making huge amounts of money from it.
They develop an extremely complex system.
Yes.
And they make money on that complex system. I certainly don't understand the way that it works. Just show you how complex it is. If you have a particular drug, go on the internet and look at GoodRx and see the huge difference in what you have to pay at different drugstores. And you can also try to figure out what GoodRx is doing. I've had a discussion with my son and my stockbroker about GoodRx. and you can save a lot of money. I don't know exactly how they're making money. I think they make money by advertisements that they have on their websites. Also, they have a fee that they charge patients, and they also have complex relationships with different pharmacies. But GoodRx may be a way that a for-profit company can decrease the cost of drugs. We'll have to wait and see. But their system is also complex, but I can tell you from personal experience that you can save money by doing that.
Now, the obscurity that exists here is important because
Right.
that's how they function. Now, the way I understand it, and I this is 3 levels above my pay grade. They make money, revenue from the supply chain, okay? And that involves all these people. It involves the customer or the patient. It involves the pharmacy. It involves the insurance company. It involves Medicare. It involves the drug manufacturer and the wholesale distributor. So they get rebates from manufacturers, and I'm trying to figure out how exactly that works. If Purdue Pharma makes a drug, and then they will then the drug is then sold to a wholesale company that then sells the drug to the Kroger pharmacy. These guys are getting a piece of the action, each step of the way. They make money on something called the, quote, spread, unquote, quote, which is a difference between what the pharmacy benefit manager pays from the drug for the drugs, how much is paid by the insurer, and how much they charge the patient. I mean, this is a web, a spider web of confusion, and these people they're not stupid, but this is the kind of this is what you're dealing with when you say, well, we can save a lot of money if we don't have to do all these things, well, how are you going to get rid of these people? Because they've got their hands in the cookie jar up to their elbows.
Well, another interesting thing is that the managers work out different deals with different drug companies. But I can pull up on my iPhone here and pull up a specific drug, and it will cost you different prices at Kroger, Walmart, CVS, etc. And it's amazing some of the differences. There can be like up to $100 difference. And how that works, I don't really know. And I can tell you most pharmacists don't really know how that works.
Now, the reason nobody knows that I figured out from doing all this research on the internet is this is all, and I don't know who makes these decisions. All of this, the mystery behind all of these activities, as opposed to transparency, is considered proprietary information.
That's correct.
Which is a bunch of crap. And nobody knows what they're doing. And the people who are getting screwed are the customer or the patient when you go to the pharmacy.
Another interesting thing that can happen, you can go to the drugstore and pay cash for a drug and get it much cheaper than if you use your insurance. Let's say you got Medicare and you got a Part D insurance. If your insurance pays for this drug, then the manager, the pharmacy benefit manager, may make money because they're paying more than you would pay for cash.
Now, if you think things are bad, hold on to your seat because it's going to get worse. Because there's, in the process, Cigna, for-profit insurance company, which is another nightmare from the standpoint of healthcare costs, is in the process of merging with Express Scripts, which is a big pharmacy benefit manager company. That's just one example. The second example is CVS, which is a combination of pharmacy chains, pharmacy benefit managers, now owns Aetna. I mean, this is becoming a monopoly nightmare where all these for-profit entities are coming together in order to extract more and more and more money out of the healthcare system that's not going to be used for healthcare. And it's just going to be lining the pockets of these people who are exploiting the vulnerability in our system because we don't have a system.
It sounds like you're recommending that you buy some of those stocks. You might make a lot of money. Now, other private insurance companies also have their own pharmacies.
Yeah.
And they sell drugs online. Now, I'll tell you something else that's interesting that I only found out about a couple of days ago. Telemed is becoming extremely popular, and some companies, let's say you need a drug, let's say you need Cialis, and you don't have a primary care physician. You can get online and request this drug, and the company who's selling it can get a doctor online on telemedicine and write you a prescription after they get some information from you. Where this is going to go, I have no idea. But there are a lot of interesting variations going on with telemed.
Well, it ain't going anywhere unless somebody's got some political will in this country. One of the other things that I did was I tried to find out about pharmacy benefit managers in Canada, Australia, and Europe. And just like I couldn't find any information about medical bankruptcies, I couldn't find any information about pharmacy benefit managers. So I guess I may be making an assumption, but if you can't find anything about those things, that probably don't. It's probably not an issue. Probably
Yeah.
doesn't exist.
They don't exist in Canada.
Yeah.
The Canadians buy their drugs. There's a committee that bids for the drugs. If the drug company's unhappy with what they bid, they can appeal that to it's kind of like an appeals court or appeals committee. And most countries buy their drugs that way. The VA does the same thing, and the military does the same thing. But Part D of Medicare, it's against the law for Medicare to bid for drugs.
Yeah, I know, that's insane. And again, hopefully somebody's going to get a hold of this this system and change it. Okay, that's one example. I know we could go on and we could rant about this.
Well, I'm already getting angry, so let's just go to something else.
Well, I don't. The next one's not going to make you feel any better. Okay, so I'm going to ask you a question. What is the goal, the mission, or the purpose of a for-profit, investor-owned health insurance company?
That's to make money.
Exactly. It is to make as much money, to keep and make as much money as possible. And they're very good at it. They do a really, really good job. There are over 1,000 for-profit health insurance companies. They have some 20, 30 different plans. The quality of coverage is going to be dependent on the premiums that are paid, whether it's paid by the individual or whether it's paid by the employer or a combination of the two. Big premiums, good coverage. If you have a large group, before I retired, I was part of the University of Louisville. University of Louisville was self-employed. I'm sorry, self-insured, self-employed. Mouth is going faster than the brain. Self-insured. So they would hire a for-profit insurance company to manage the plan, but they don't make any profit from the plan. They just manage it and dispense it. And I had really good coverage, and it was at really low cost. Now, do you both remember we had a nice lady, a retired OBGYN, on not too long ago, and she was telling us how after she retired from her small, I think she was in a small group practice, she and her husband, who was a dentist in a solo practice with about 2 or 3 people in the office, and so the other people in his office apparently had health care from some other organization, so they weren't, he didn't have health care in his practice. So the two of them, the gynecologist and her husband, the dentist, their health plan was, it cost $10,000 a year, and she had $8,000 deduction. So the health care didn't come in, didn't kick in until she'd worked. Didn't they spend $8,000? And I have another friend out in Crested Butte who's a small property manager. He and his wife had this and they had the very same, similar sort of outrageous numbers of a huge deduction and an outrageous premiums.
Almost all the self-insured people have deductibles like that.
Yeah.
And it's becoming almost impossible to buy that and sustain it unless you're making a lot of money. Most people in Campbellsville, Kentucky, don't have that much money to spare.
And then, so the other issue and these people in the for-profit health insurance companies as well as the pharmacy benefit managers don't provide health care. They are basically bean counters and bureaucrats within the system that are playing the system for their profit. So what we have now with the for-profit health insurance companies is this incredibly complex system that the patient must endure in order to get their coverage paid for, and that the provider must endure in order to get paid. So you've got pre-authorization. I remember when we had Ted Young, the surgeon from Canada, we had asked him about, how much of an issue is it if you get a scan, it's not very good quality, and then you need to get a better quality scan in order to do it. It's not an issue. They didn't have the issues up there. There are co-payments, every time you walk into a physician's office, your co-payment, it could be anywhere from $15 to $40 or $50, depending upon what kind of a plan you had. You've got deductibles. You've got coverage denials. So if you have a really lousy plan that doesn't cover anything, you may not get, if the wife gets pregnant, she may not have any maternity benefits. I mean, this stuff is awful. Surprise billing, where the different organizations have got signed up people, and if you happen to go into the emergency room because you dropped a pot on your foot and you get an x-ray, and then the radiologist who reads it is in Norfolk, Virginia, reading x-rays on his computer, and you get a bill from him that's a lot more money than you otherwise would, or where you go to the emergency room, or you go to have an operation done, and the anesthesiologist. There's all kinds of examples of this stuff. And then there's co-insurance. I mean, so you've got insurance, and you have to get more insurance, and then uncovered services, and the resources from all that end up going into the pockets of the CEOs of the insurance companies are making $20-30 million a year, and they're just the top of the food chain. When you go all the way down, the amount of money that these people suck out of the system is enormous.
Well, we haven't talked about equity companies controlling facilities, and
We've only got 5 minutes left, so I'm not sure we're going to be able to get to
I don't know
that.
what you can say, but I just found out a few weeks ago that all the nursing homes except one in my surrounding area are owned by equity companies.
Yeah.
Now, I assume that most of you know that equity companies are companies that where investors put money, and the equity companies buy other companies, but they expect to make quite a bit of money. They expect to make at least 10%. Now, if you buy a nursing home, there's only one way that you're going to make money, and that's decrease your expenses. There may be a few rare nursing homes who have private care, their patients are paying $10,000 a month, but most nursing homes are filled with Medicare and Medicaid patients, so that nursing home is only going to get a limited amount of money, so the nursing home is only going to be able to make money by decreasing their overhead.
Gene, let me suggest that we, since we're so short on time, let's plan to do a part 2 of this,
Okay.
and get into the nursing homes, and even get back into the for-profit insurance companies some more, because there's a lot about that we haven't discussed. But let me just kind of finish up with a couple of issues here about where the money goes. So this is, again, New York Times article in November 17, 2019. In 2018, single quarter profits. This is not revenue. This is single quarter profits of 85 top publicly traded health insurance companies. These are the for-profit insurance companies. These are only 85 out of the 1,000. This is one quarter. $47 billion. So if you add that and multiply that times 4, it's just going to be, something under $200 billion. And I just got one more figure. I got this morning. Yes, I was drinking my cup of tea before I left here. In 2019, next year, United Healthcare made $14 billion in profit and had $242 billion in revenue. And CVS, which we just talked about, which is the pharmacy chain, the pharmacy benefit manager, and now owns a for-profit health insurance company, made $6.6 billion in profit. This is just 1 year, 2019. And the annual revenue for the same year, 2019, was $257 billion. These are huge amounts of money. And what I would suggest that we do when we come back and do this again is to pick up where we are here and go through some of the issues of where's this money going? Because the profit is just the icing on the cake. They're spending money on doing all kinds of other things, including huge political contributions to keep this system the way it is. How much time have we got left, Mark? We're down to the end of the live.
Well, we're about there, Mike.
Okay. Well, let's do this. I think we've got a lot more to talk about in dealing with the bureaucrats and the bean counters, the for-profit insurance companies, and we haven't even gotten into the investor-owned companies. So let's throw the towel in and come back another day.
We've got $1 billion worth of stuff to talk about.
Well, Mike and Jean, as we're talking about nursing homes, I have a friend whose dad in his early 90s, dementia's taken hold. And it's not just trying to care for the interest of your senior parent, but it's also the complications of even applying for Medicaid and the whole issue of different elder care attorneys and their practices to help people navigate an application process. So it's the thing about a single payer system, it simplifies everything. We don't have all these opaque hoops to jump through and where's the money going? It goes to healthcare.
Now, but next time we get into that, bring that up, because I've got a story about a friend of mine who was who practiced a primary care physician in England, and when I'd visited with him, and a visit we took to nursing homes.
Okay. And also, I want to tell our listeners that if you go to the Center on Budget and Policy Priorities, they've got some real good information about what's happening with increasing access as part of the COVID-19 relief legislation that's going through committees and going to be coming up for a vote. It's not single payer, but expansion for Medicaid and some other things that are going to help folks out. The website for the Center on Budget and Policy Priorities, cbpp.org, cbpp.org. And Our listeners can get more information about Kentuckians for Single Payer Healthcare by going to kyhealthcare.org. That's kyhealthcare.org. And if you have comments or suggestions for shows here on Single Payer Radio, you can contact our chairperson, Kay Tillow, at nursenpo@aol.com. That's nursenpo@aol.com. And also, I would encourage folks to support Forward Radio. You can also listen to past shows of Single Payer Radio by going to forwardradio.org. That's forwardradio.org. Guys, a lot of very valuable information that we're basically, our health is a profit center for folks playing the stock market, and you know, it's a gamble.
It's a commodity.
Yes.
That's the issue.
Gene?
I have nothing else to add. It's a commodity.
Okay. Gene, thanks for driving up from Campbellsville for our shows. Mike, the jog over from Cherokee Park. And listeners, we'll talk to you next week. Thank you very much.
Thank you.